Hello, everybody. My name's Mark Bullimore. I'm affiliated with the University of Houston, but I live in Boulder, Colorado. And the view you can see behind me is from my deck on a slightly foggy morning by the looks of things. So I'm going to be talking to you today about myopia. Before I go on, I need to disclose that I make most of my living from consulting with companies, and many of them, you can see on the left, have an interest in myopia. Now, the material I'm going to talk about today is going to be based on largely peer-reviewed literature. I don't see patients. So if you go to my website, bullers2020.com, you'll see on the front page, there's a link there to recommended reading on myopia management. And a lot of the papers I'm talking about today are listed on that page, and you can click on the links, and most of them are open access, so they're not behind a paywall. And likewise, I don't ask you to register on the website or try and sell you something. This is just a parking spot for information that I regard as important. So why myopia and why now? When I was at optometry school, which was about 40 years ago, we regarded myopia as a benign refractive condition that we corrected with spectacles and contact lenses. Nothing too much to worry about, but our opinions have changed as our knowledge has increased. First of all, we know that myopia is increasing in prevalence, particularly in Southeast Asia, but it's also rapidly increasing in the United States. Secondly, we have a much better understanding of the role myopia plays in eye disease and visual impairment. So to take you on a little journey into that, a few years ago, my colleague and I, Noel Brennan, published this paper, which garnered quite a bit of attention. And the basic premise here is that there's three long-term benefits of lowering a young patient's ultimate level of myopia. They'll have better vision, both uncorrected and corrected. They'll have better options for surgical myopia correction when they reach adulthood. And there will be a reduced risk of visual impairment that we associate and we see with higher levels of myopia. So let's think about the first item first of all. We know, of course, that the higher myope has poorer uncorrected visual acuity, but as I'll show you in a minute, they also have poorer corrected acuity. They report more difficulties performing everyday tasks and more challenges related to their vision. And of course, somebody who's a -8 is more dependent on their correction than somebody like myself who's about a -2. And because of that, we know that high myopes, and indeed high hyperopes actually, take more risks with their contact lenses. Now, our friends, the refractive surgeons, one of whom you're hearing from during this program, have a saying that the shorter putt is easier to sink. And what they're saying is that with lower levels of myopia, it's easier to achieve residual or minimal residual refractive error. That means better postoperative uncorrected acuity and the need for fewer secondary enhancements. It also means, of course, that we need to remove less stroma, as most of our procedures are lamellar in nature. And if you have higher myopia, thinner corneas, or both, then there's both an increased risk of corneal ectasia and the need to consider alternative procedures such as phakic intraocular lenses. The lower myopes are also going to achieve both better postoperative visual acuity. And we found this in a paper that some colleagues and I published, probably getting on 20 years ago. And the refractive surgeon on this paper is my friend and colleague, Robert Maloney. And Robert practices in Los Angeles and is kind of a refractive surgeon to the stars. So it's kind of fun to go to his website and look at some of the testimonials. Being a child of the 70s, I remember Captain Kirk and the Fonz from his patient list. But anyway, in this paper, we measured visual acuity in a number of different ways. So if you look at the top left-hand panel that I've highlighted here, we're plotting visual acuity preoperatively and then postoperatively in those myopes with low myopia and those with high myopia. And what you can see is that better acuity is lower on the graph. You can see that both preoperatively and postoperatively, the low myopes have better visual acuity by over half a line. Now that's with natural pupils and with a high contrast visual acuity chart that you might use in your consulting room. If we take a more stringent measure and we dilate the patient's pupils and we look at low contrast, we can again see preoperatively there's a difference between the two groups, but that difference is exaggerated postoperatively. There's a reduction in visual quality in both groups, but it's much more dramatic in the higher myopes, and that of course is due to the increased spherical aberration. So the third on our list is the association with lower levels of myopia with reduced risk of visual impairment. And again, when we were at optometry school, we would have learned that higher levels of myopia, or indeed myopia in general, was associated with a number of diseases. But the greatest myopia-related cause of irreversible vision loss is a thing called myopic maculopathy, also referred to as myopic macular degeneration. So this is sort of the spectrum, if you like, for classifying myopic maculopathy. In the top left, we've got a myopic tessellated fundus. That's not classified as such as myopic maculopathy. The entry level for myopic maculopathy is in the middle of the center, where we've got diffused atrophy. And you can see the vessels showing through because of the chorioretinal atrophy in this patient. Now, that can progress later in life and in more severe cases to either patchy atrophy, lack of cracks, Fuchs spots, all these sort of things, and even eventually choroidal neovascularization. So that's myopic maculopathy. Now, in this paper that Noel and I published, we identified 5 large epidemiological studies that had looked at the prevalence of myopic maculopathy as a function of the level of myopia. And these represent 5 studies from 3 continents in over 21,000 patients. And what you can see is that all of those studies, regardless of location, have an exponential relationship between the likelihood of myopic maculopathy and the degree of myopia. But when we plotted those data on a logarithmic scale, something interesting happened. All of the data seemed to fall on a very similar gradient, and the average slope of those 5 lines is 1.67. So what that means is that each additional diopter of myopia increases the risk of myopic maculopathy by about 67%. Turning that on its head, each diopter less, or each diopter that we could prevent, would reduce the risk by 40%. So a very big public health benefit of potentially lowering a patient's level myopia. Now, a couple of other things that are interesting from these papers. Around half of the cases of myopic maculopathy were in myopes below 5 diopters. Okay, and that's of course because there's more people like me, -2, than there are people at the higher end of the spectrum. But that reminds us of the phrase coined by my colleague Ian Flintcroft, that there's no safe level of myopia. And in fact, I want you to stop thinking about myopic maculopathy as a disease of high myopia and remember these statistics and think of it as a disease of myopia. Now, some of us extended that work to a paper that was published a couple of years ago in the Journal of the American Academy of Ophthalmology, and we looked at some other diseases. Here's some data on primary open-angle glaucoma, again plotted on a logarithmic scale, and you can see that each diopter, regardless of the country, increases the risk by about 20%. Now you may say, well, those lines look like they're separated vertically. That's because of the different criteria for glaucoma used in these different studies. A similar thing's observed with posterior subcapsular cataract. this is the one type of cataract that is, if you like, associated with myopia. Of course, we associate nuclear opacity with myopia, but there it's the opacity causing the myopia. Here, it's the myopia causing the PSC. And again, you can see a relationship of about 20%. And the one you were probably expecting, retinal detachment, a range of studies in different countries showing that on average, each diopter increases the risk by about 30%. And you can even see some old data from Switzerland looking at the lifetime incidence, which of course is a much higher, again, showing a very similar relationship. Now, you might say, well, those are diseases. That doesn't necessarily mean visual impairment. Well, fortunately, this paper was published about 5 years ago, and it takes data from the Netherlands on a number of large, carefully followed data sets from epidemiological studies. And in this paper, they have 15,000 patients with both visual acuity data and refractive error data. And in fact, there's a subset of them in whom there's axial length data. But what they found was a relationship between level of myopia and visual impairment, with visual impairment increasing with age. And you can see that the lower levels of myopia, there's not much visual impairment, but as you go to sort of higher levels, that prevalence increases dramatically. So in that risk-benefit paper that I just mentioned, we replotted those data. So we took 5 different age bands, and again, we plotted the risk of visual impairment as a function of level of myopia. And you see the same sort of exponential relationship that we've been seeing throughout here. Now, again, when we plotted those on a logarithmic scale, the lines were pretty parallel. So if you look particularly down at the 2 to 8 diopter range on the left, you can see that the slopes are very similar regardless of the ages of the patient. And you want to know what that ratio is, or sorry, that slope is. The slope's around about 1.3. So every diopter of myopia increases the risk of visual impairment by around 30%. Turn that on its head, every diopter that we might be able to prevent could reduce the ultimate level of visual impairment later in life by 25%. So again, that's a huge public health significance. Now, we've extended some of these numbers to come up with some additional statistics, and assuming that half the world's going to be myopic by the middle of the century, we can estimate that about 3% of the 10 billion people will be visually impaired using a criteria of 2040. But myopes are going to be overrepresented in that population. They represent about 2/3 of the population. And we can calculate that around about 1/3 of all cases of visual impairment will be attributable to myopia. And in fact, myopia plays a much greater role in the working age population because things like myopic maculopathy occur a lot earlier than age-related macular degeneration. So going back to the rhetorical question of why myopia and why now, well, we now have the ability to do something about it. And I often draw the analogy with dry eye. Dry eye was not a big deal in our profession 20 years ago because we didn't really have effective ways to manage it. Now we have drugs and sort of mechanical heat-based therapies that we can actually treat dry eye disease or meibomian gland dysfunction in a very proactive and effective way. And the same is true with myopia. We knew it was maybe not necessarily a good thing, but we didn't have any ways to slow it, so we didn't have those conversations. But now we've got a range of therapies that are available to us, and given the right approach or the right subset of these, all of these have the potential to slow myopia by a meaningful amount. And I think some of my colleagues are talking to you this weekend on spectacles and atropine and maybe on some contact lens therapies as well. But before we get into some of the details, and I am going to give you sort of my 30,000 view of these things, I want to remind you that we live in an evidence-based world. We are increasingly being called again to practice evidence-based medicine or evidence-based optometry. And this is the evidence-based pyramid, where we have the highest standard of evidence at the top being randomized clinical trials, and opinions such as experts like me is down the low end. Now, of course, we could even have a higher level of evidence, a thing called a meta-analysis, where results from a range of different studies, hopefully randomized clinical trials, are combined to come up with a more definitive answer. And of course, there's also people down the bottom of the pyramid, social media and politicians, that we should never get for our medical advice. Now, when it comes to myopia, there are certain things that we like to see in a peer-reviewed paper. We like to see randomized clinical trials, and we like to see them lasting about 2 years or more for reasons I'll explain in a minute. We like to see masking. We don't call it blinding, but we like to see the patient, if possible, masked to the treatment they're receiving, and also the person taking the pivotal measures in the clinic or the center. We like to see them masked to the allocation of the patient. Now, we can measure progression 2 ways. We can use refractive error or axial length. If we're doing refractive error, it's imperative that we use an autorefractor, because that eliminates a lot of bias that we associate with a subjective refraction. And we like to use cycloplegia, because that will again improve the repeatability of our measures. Axial length actually is much more repeatable and much more precise if we use one of these modern optical biometers. And of course, we would expect in most cases there to be a correlation between myopia progression and axial elongation. And for the sake of this presentation, you can think of about 0.1 millimeters of ocular elongation corresponding to about a quarter diopter of progression. You'll also see that I tend to talk about efficacy in millimeters or diopters and not in percentages. And I'll circle back on that one just a minute. When we are looking very closely at some of our clinical trials, I have a strong preference for looking at axial length data rather than diopters. There's a stronger association with visual impairment. You don't need to cycloplegia. As I said before, it's much more sensitive, much more repeatable. And of course, with things like overnight orthokeratology and to some extent atropine, they're affecting the refractive components of the eye. So dioptric measures of myopia progression will no longer be valid. As I said before, we like to see, I have a strong preference for talking about absolute treatments and avoiding percentages. That's because when you look at a lot of data, the treatment effect in millimeters or diopters tends to be constant across age, across underlying progression rate, and across races. And we have a paper that just came out on the issue of race. Percentage treatment is not. The other thing is that we would hope that our absolute treatment, our absolute reduction in axial elongation will accrue over time. There's added benefits of additional years of treatment. But a hallmark, certainly, of optical treatments for myopia control is that we get the biggest bang for our bucks in the first year, and then we get still a significant slowing of axial elongation in the second and third year, but it's not quite what we see in the first year. So if you have a 3-year study, you can normally expect half of the treatment effect to be in the first year and the remainder in years 2 and 3. So let's talk about some things that may or may not work. Spectacle lenses, there are some effective treatments on the horizon, but there's a couple of things that don't really work that well. The first is undeminusing. So here's a couple of clinical trials that were published somewhere between 15 and 20 years ago, different parts of the world, but the same conclusion. Here are the data from each of those papers, and the open symbols are the subjects who were fully corrected, the children who are fully corrected. The close symbols showing faster progression are the children who are undercorrected. So when you undercorrect a child, you do two things bad. One is you're probably, if anything, making them progress a little bit faster. And secondly, they're not going to be able to see the blackboard, and their spectacles will be obsolete at an earlier stage. So maybe it's something you shouldn't consider. Well, what about PALs? Again, in the early part of the century, there were a number of randomized clinical trials. These were two of the first and two of the largest. The one on the left is from Hong Kong, the one on the right from the US. And what you can see is that there's a small, modest slowing of myopia with PALs, but it's an effect that is really clinically worthless. So there's, if you look on the right at the COMET data, that's from the US, there's a slowing of less than a quarter diopter over 3 years. But if you look at the graph, most of that slowing occurs in the first year. There's no additional benefit of wearing the lenses beyond that. Now, the folks from the COMET study, they did do a subgroup analysis. It's like, okay, we've got an unimpressive result. Are there some subgroups of children that might show a bigger effect? Well, the group that they identified in this subgroup analysis, sometimes referred to as a fishing expedition, is that the subjects with larger accommodative lag and esophoria seem to show a greater benefit. Now, for some people in the field, that's all they needed to hear. PALs work in esophores. It's a settled issue. But the investigators did another clinical trial because they appreciated that that was an exploratory finding. They needed something more definitive. So in a study called COMET-2, they recruited just children who had myopia, esophoria, and an accommodative lag over half diopter. What did they find? Pretty much the same as the overall result from the first study, only about a quarter diopter slowing over 3 years. So even in these lag-in esophores, PALs are not a good therapy. We'll come back to spectacles in a minute. Now, there are a class of optical interventions that are effective, and they all have something in common. They all do something to the peripheral retina by bathing it or exposing it to more positive lens power. And it doesn't matter whether it's ortho-K, some of our contact lenses, or some of our new spectacle lenses, they all work on this same principle. So why would we care about the periphery? Well, there's a set of very careful and exquisite experiments conducted by my colleague and friend Earl Smith at Houston, and many of his collaborators. And they demonstrated, first of all, that you could regulate a neonate animal, a very young monkey's refractive error, by adding plus or minus lenses. If you put a minus lens in front of the eye becomes more myopic, and the opposite for a plus lens. They also found that the fovea wasn't essential. But two of the important factors are that when you put the fovea and the periphery in conflict, the periphery dominates. Okay, so it doesn't matter what you do to the fovea. You can correct the vision, give a monkey or a child clear distance vision. What you expose the periphery to is important. Likewise, if you have two conflicting signals in the periphery, the more positive signals dominate. And really those two key findings are the underpinning of most of our successful optical therapies that we use today or will be using in the future. So let's talk about orthokeratology or corneal reshaping. This was the first peer-reviewed study, and the authors, Pauline Cho and her colleagues, followed a group of ortho-K wearers for 2 years and looked at their axial elongation and then compared them to a historical cohort of spectacle lens wearers, actually from the Hong Kong PAL study I showed you earlier. And what did they find? About a quarter millimeter slowing of axial elongation over 2 years. But again, not a randomized clinical trial, but you can see a big chunk of the effect is occurring early on in the study. Well, they went and did the first randomized clinical trial where children were actually randomized to ortho-K or spectacles, and what they found was exactly the same. About a 1/4 millimeter slowing over a 2-year period, and that corresponds to about 0.6 of a diopter. Now, I mentioned meta-analyses earlier. There are a number on orthokeratology. They all use the same papers in their analysis, so they all end up with the same result. And what you can see here, regardless of whether you're looking at studies in Europe, North America, Japan, China, Hong Kong, everybody pretty much finds a very similar result, a 2-year slowing of about 0.25 millimeters. So what about contact lenses? I'm going to share 3 sets of results with you because they're all at least 2 years in duration. So this was a study that was conducted by the Brian Holden Vision Institute. It was actually conducted in China, but they had 500 children, myopic children, and they randomized them to 5 different lenses. They had a control lens, a single vision soft lens. They had 2 that were kind of concentric designs, and then they had 2 that had extended depth of focus. What did they find? Well, the control group progressed pretty much as you would expect, but all 4 of the experimental designs slowed myopia and slowed axial elongation by about 0.15 millimeters over the 2-year period. So one of those EDOF designs is currently available in Europe from a company called Mark Bullimore. The lens that is approved in the United States is the MySight lens, and it was approved on the basis of their 3-year clinical trial of around 120 myopes. What did they find? About a 0.7 diopters slowing of myopia, about a 0.3 millimeters slowing of axial elongation. And as you might expect, those 2 factors were correlated. So you can see here that if you're whether you're measuring refractive error or whether you're measuring axial length or both, you should be able to monitor progression. So axial length is perhaps the wave of the future, but you shouldn't use that as a barrier to entry into myopic control. You can start doing myopic control even if you don't have a biometer. And then the 3rd study, which was the BLINK study, this was a government-funded study conducted at the Ohio State University and the University of Houston. 300 children randomized to one of 3 soft lenses, either a single vision lens or 2 kinds of distant center multifocals, one with a 250 ad, the high ad, and one with a 150 ad, the medium ad. And almost all of the children completed the 3-year study, so kudos to the investigators. What did they find? Well, over 3 years, the single vision kids progressed by about a diopter and grew by about 2/3 of a millimeter. The medium ad wasn't that much different from the single vision, but there was a significant slowing with the children wearing the high ad, almost half a diopter and over 0.2 millimeters. So not quite as effective as you see with the MySight lens, but remember these lenses are available in toric form, so this may be something else to consider. So what about spectacle lenses? We've circled back around. I've told you under -N and PALs, neither are a particularly good idea, but what about a spectacle lens that has plus power in the periphery of all meridians? So the first investigation was on some prototype lenses, again at the BHVI, the Brian Holden Vision Institute, and these were like radial progressive lenses. So the plus power increased in different ways in the 3 types of experimental lenses. But as you can see from the graph here, the controls were not that much different than the experimental spectacle lenses, with the possible exception of the type 3 lens. And again, with a dreaded subgroup analysis, there was a suggestion that this might be more effective in younger children with at least one myopic parent. Well, that lens was commercialized and reevaluated by a group of Japanese investigators. This time they only recruited younger children with at least one myopic parent. What did they find? Butkus. No effect of this lens. This is an ineffective therapy. Now, things got a bit more interesting with some more novel designs. And this is the lens that is called the Defocus Incorporated Multiple Segments lens, or DIMS for short, DIMS. And you can see that there's this honeycomb array of lenses or lenslets in the periphery of the lens. They're all about 1 millimeter in size. They all contain about a +3 diopter, +350 ad. So the investigators conducted a 2-year study with some very promising results. Among the children who completed the 2-year study, the progression in the single vision lenses was almost a diopter and about 0.5 millimeter, but it was substantially less in the children wearing the DIMS lens, about a 0.5 diopter of slowing, about a 0.3 millimeters of slowing of axial elongation. Well, since then, Essilor has developed their own lens. It's marketed as the Stellus lens, but it incorporates highly aspherical lens technology. So not only do you have these lenses in the periphery, they're also aspheric in their design, and the power varies such that there's always a meaningful positive power regardless of where you are in the peripheral retina. Again, they're about 1 millimeter in diameter, but they're arranged in these concentric circles. The investigators recruited almost 200 children, myopic, and they randomized them to 3 different lenses, either the highly aspherical lenslets, the slightly aspherical lenslets, or a control group wearing single vision. So in those that completed the 2-year study, you see about 1.5 diopter of progression, about a 0.7 millimeter axial elongation, and particularly in the HAL lenses, the highly aspherical lenslets that are being marketed now as the Stellus lens in parts of the world, you see over 0.75 diopter of slowing of myopia progression and about 1/3 millimeter of slowing of axial elongation. Now, none of these lenses are available in the US right now, but I know at least the Stellus lens is being evaluated as part of an FDA clinical trial. Another lens that I'll mention briefly, because it is closing in on their regulatory process in the US, is a thing called the sight glass vision lens. And this isn't refractive in its design, it's diffusive. There's these diffusing elements in the periphery of the lens surrounding this 5 millimeter clear zone. So the investigators have already published 12-month results. They presented the 3-year data at some scientific meetings. But to cut to the chase here, what they've found is that there's a significant slowing with both of these designs. And one of the designs has already been marketed. It's available in Canada and parts of Europe. And again, hopefully at some stage in the foreseeable future, it'll be available in the US. So what about pharmaceutical approaches? Well, beta blockers were a nice idea, but they're ineffective. And atropine is the most effective of our current options. Atropine's been used for decades, but the modern era of research and the modern era of rigorous clinical trials began with a study called the ATOM study, which was published about 16 years ago. And in this study, they randomized children to 1% atropine or a placebo. It was a unilateral study. So the children on atropine weren't completely debilitated by the profound cycloplegia and mydriasis. They just probably got teased at school because they had one pupil much bigger than the other. But anyway, in the placebo eyes, there was about 1.25 diopter of progression, but only 0.25 diopter progression in the atropine eyes. The corresponding data for axial length, they agree pretty well. Virtually no change in axial elongation in the atropine eyes, about 0.4 millimeters of growth in the placebo eyes. But one of the challenges of this study was, as I said already, it was a unilateral study, but it also showed profound rebounds. So if you look at the data at the top line there, those are the atropine-treated eyes and their axial length. In the year when after treatment was discontinued, those eyes kind of went boing, and they progressed by over a diopter and grew by 0.3 millimeters. That's almost as much as the placebo eyes grew in the first 2 years. So rebound's clearly a problem in higher concentrations of atropine. Now, they went on to do another study, ATOM2, where there was a suggestion that lower concentrations were almost as effective as the 1%. And in fact, the surprising thing was the 0.01% concentration seemed to slow myopia by 0.7 diopters, okay? But there's a problem, okay? The refractive error data from this study and the axial length data disagree. Refractive error data on the left, axial length data on the right. And let's concentrate just on the 2-year data. Now, they look pretty similar until I colorize the placebo and the 0.01. And you can see a robust slowing of myopia. But on the right, you've got nothing in terms of the slowing of axial elongation. And the challenge is here, this was used in an historical control group from the first study. Now, since then, there have been a number of studies looking at lower concentration using more rigorous randomized clinical trial methodology. And perhaps the one you're most familiar with is the LAMP study, where they compared a placebo with 0.05, 0.025, and 0.01. So let me show you the refractive error and the axial length data side by side. And what you can see is that there's a nice dose response effect. The untreated eyes are the placebo, the yellow lines, and you can see that, and I've circled it for the at the bottom there, the 0.01% has a very modest effect on axial elongation, but the higher concentrations, particularly the 0.05, have a much more robust effect. Now, since then, there's been a number of other clinical trials, and the picture is becoming fairly clear in so much that we are seeing about a 0.2 diopter slowing of axial elongation with 0.0. Let me say that again. We're seeing about a 0.2 diopter slowing of myopia progression with 0.01% atropine. And we're seeing about a 0.07 millimeters of slowing of axial elongation. The researchers in the LAMP study have also looked at washout, and to cut to the chase, in the lower concentration and in the older kids, we don't seem to see much in the way of rebound, but there is some suggestion of rebound in the orange lines there, which are the higher concentrations, and it's particularly marked in the younger kids. But of course, we're not going to be taking young kids out of atropine. We're going to probably stay the course in terms of treatment. So one other thing I want to talk about before I take your questions, and that is to talk about repeated low-level red light therapy, or RL, okay? And this is a therapy that's provided by a desktop device, typically. The illuminance provided by the red light's about 1600 lux. That's about the same as going outside with your eyes open on an overcast day. Now, curiously, with this therapy, it's just administered for 3 minutes a day, 3 minutes a session for twice a day. And the results are really quite remarkable. So in this particular study I'm showing you here, multi-center, randomized, single mask, because the kids obviously knew what they were receiving. Over 200 children who are randomized either to the intervention or control. And what you can see here is over a 12-month period, a really dramatic effect. In the control eyes, you got progression of about 0.8 millimeters and axial elongation of about 0.4 millimeters, but it's substantially less in the eyes receiving this red light therapy. So this is something to watch. There are some barriers to it coming to the US, not at least the FDA, and also some safety issues concerning the light levels with this particular therapy. But something I wanted to tease you with. So what's next and what's needed? You're going to see a steady cascade of data, both from US-based FDA trials on drugs, soft contact lenses, spectacles, over the coming years. So pay attention, because it is important that we have data on kids that look like our patients, because most of the data thus far on both Atropine and spectacles with these new designs has been based on East Asian therapies. It's also going to be curious to see how combination therapies work. And something else that we'll talk about another time is the issue of myopia prevention, because as Benjamin Franklin said, an ounce of prevention is equivalent to a pound of cure, and we could do a lot for the myopic destiny of our young patients by starting them on preventive measures rather than waiting for them to develop myopia. So thank you again. I'm easy to find if you remember Buller's 2020. Go to my website if you want to find some more papers and do some reading. But other than that, I thank you for your attention.
All right, everybody. My name is Dr. Mike Cooper. I am the co-moderator of Eyes on Myopia, and I am just blessed and graciously, just looking at this view from Dr. Mark Bullimore's, spot in Thailand right now. Totally jealous of you, but thank you, Mark, for being here in the morning over in where you're at right now.
It's a pleasure to be here. It's yeah, I had to get up a little early, but it's approaching 7:30 here, so it's civilized. And yeah, I'm speaking in Singapore next week, so took a little extended trip, so little beach time and some other activities. So anyway, thanks for everybody for being here, and let's do a few questions. Coop, birthday boy.
Absolutely. So I bracketed them out, so we'll get this going. What is considered undercorrection? As low as negative 0.25?
Yeah, of course. I mean, one of the challenges is the myopes progressing. So what actually counts as under correction? So in the studies I referenced, it was 050 to 075 was their systematic undercorrection. So I think for a number of reasons, keep our kids' prescriptions up to date.
Makes perfect sense. I'm completely on board with that. Would correcting a low hyperop with a low hyperopic spectacle before they become myopic prevent or delay the myopic progression? Has this been studied?
It hasn't been studied in any rigorous way. We know that the less hyperopia a child has, the higher the risk of becoming myopic. So if you cycloplege and refract the 6-year-old, if they have less than 3/4 of a diopter of hyperopia, then they're at risk, and you should think about some sort of preventive measures.
Makes sense. Now we're going to get into atropine a little bit and talk a little bit about what that looks like in the grand scheme of things. We'll start with the parents. So what do you tell parents who worry about long-term effects of atropine?
Well, remember, we're dealing with very low concentrations. There are some data out there which shows that with oral high-dose antimuscarinics, anticholinergics, you can get dementia in older adults. But we're talking about, tens of thousands, almost 100,000 higher levels of dosage here. We're dealing with a topical drop. So I don't think there's any concerns, and certainly the FDA has sort of signed off on 1% atropine as being safe. So when we're down at a 20th or 100th of that, nothing to worry about.
Right. And obviously we're not drinking this. It's topical administration. So I think that also, helps to wash it out too. So along that same line, what is the maximum amount of years that patients can safely use atropine drops?
I I think you need to be in it for the long haul. I mean, obviously, you can switch to other methods if you want to get the kids off the drugs. But, you know, we should be in it for sort of 2-5 years, maybe longer. And if it's well tolerated, and remember, it's a sort of it's a natural drug. It's not something that's been engineered. So keep the kids as long as on it as they need to be.
Right. That makes sense to me too, considering the fact that it isn't a long-term, you know, it's not part of their long-term habit essentially for the rest of their lives. All right. So now we're going to switch to a question about pathophysiology. What about intravitreal injections for myopic maculopathy patients, especially for those who might be at risk or suffering from a CNVM?
So certainly, you know, if you've got choroidal neovascularization, just like other retinal diseases, then some sort of anti-VEGF treatment should be an option. But I'm not a retinal specialist, so I'll leave that to them. You know, the intriguing thing is we now have drugs emerging for geographic atrophy. And I asked my retina friend recently whether that would be an option for choroidal or sort of diffuse atrophy with myopic maculopathy. And her answer was, you know, the risk benefit is not in the right direction at the moment. But that's something to think about for the future, because at the moment, in the early stages of myopic maculopathy, we don't have any treatment. And just to circle back to the Q&A that came up online, I did put a link in to that paper that had the images of myopic maculopathy at different stages. So you should better get that. It's open access.
Yeah. I mean, you mentioned anti-VEGF therapy, and, you know, there are obviously, based on dosage, going back to the dosage game here from early discussion, atropine, there is some cases, obviously, a fair amount of them that could potentially progress on anti-VEGF therapy, in especially more in AMD patients towards and from dry to wet. It's one of those, you know, catch-22s. It's risk. It's that same risk benefit that you mentioned regarding the GA patients. Is it a viable intermediary? Well, it's still a story to be told, you know.
Yeah, we're still learning, because, you know, we didn't see a lot of myopic maculopathy when we didn't have as much myopia. But patients are living longer. There's more myopia. So we're going to learn a lot, and our retina friends are going to be very busy.
That they are. So we're going to switch now to a different side, talking about equipment and measurements. And we'll start off with, how's corneal curvature considered in the statistics of the effects of myopia?
Doesn't have any effect. So if you look at a group of myopes, look at emmetropes, they have the same average corneal curvature. It's all axial when it comes to myopia. So this refractive myopia that we learned about in school, it's kind of doesn't really exist.
Got it.
Or it's rare.
Understood. Now, for the private OD who's out there, not maybe in a research academic environment, is there a particular piece of equipment or brand that you might recommend to measure axial length?
So I consult with one or two of these companies, but not on a regular basis. So I'm not going to name names, but basically, if you can get a hold of one and afford one, an optical biometer, something that uses OCT technology or interferometry technology is what you want. So there are, you know, instruments out there made by Zeiss and Haagstreit and Topcon, and who am I forgetting? Oculus, that do all of these things. Now, some of the instruments are sort of Cadillac, Lexus level instruments designed for the cataract surgery, but we've seen in the last couple of years some sort of stripped down, more basic instruments designed for the myopia practice. I think, you know, at the moment we're looking at prices in the low 20,000s. That's likely to come down. I know at least one company that's developing a handheld, low-cost axial length device. It's not ultrasound, it's still non-contact and optical. So the other thing, if you don't have it in your practice, then you know, talk to your local cataract surgeon and see whether they would be able to work with you and measure axial length periodically on the kids. It's going to be their technicians that are doing it. They may say, okay, we'll charge your patient this much money to do this every 6 months, but that's a way to get in the door if you're not willing to put money down right away and on this instrumentation.
Perfect. Perfect. Well, thank you, Mark. Really appreciate your time, your expertise, and also the vista behind you. Really appreciate it. It was a
Thanks,
great
everybody. Great meeting, great questions, and enjoyed interacting with everybody. So thank you.
Beautiful. Thank you again. For everybody, here's the raffle code, MMD. MMD.